realistically, the idea that a single drug is going to do everything is probably not going to happen. So,
welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals who are dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Hello, and welcome to the Veterinary Cancer Pioneers Podcast. I'm your host, Dr. Rachel Venable, and I'm excited today to bring our guest, Dr. Steve Dow. Dr. Dow is currently a professor of immunology in the Department of Clinical Sciences and the director of the Center for Immune and Regenerative Medicine at Colorado State University. And he investigates tumor immune responses and new cancer immunotherapies. So really excited to dive into your research and what all you guys have going on there.
Okay. Thank you, Rachel. It's very nice to be with you.
Thanks so much for being on our show today. And I always like to start with just having our guests give a little bit of a background about how they got to where they are, how maybe you became a veterinarian or what got you into immunotherapy.
Okay, well, so I did my training at CSU in internal medicine. So I finished my residency and decided research might be something interesting to tackle. So became involved in studying the neuroimmunology of feline and immunodeficiency virus. This was back during the AIDS epidemic when it was really getting ramped up. And so got an early interest in immunology at that point, and then moved to Denver to the National Jewish Center for my postdoctoral training. And then that environment was immersed in people that really knew a lot about immunology. And so I became interested in using initially gene delivery to deliver immune stimulatory genes into tumor cells to trigger T-cell responses. So we worked with a gene that encodes what's called a superantigen, which is a really potent molecule for activating T lymphocytes and causing them to move into tumors and become activated and kill tumors. So we really, one of the studies I'm most proud of is our first study in dogs with melanoma, where we were using gene delivery to deliver the superantigens into the tumors, saw tumor regression in about half of the treated dogs, and a lot of them had long, durable remissions. So that was really kind of where I first got the bug for really pursuing immunotherapy. Did a lot of work in mouse models, but also had the opportunity to work in dog models with faculty here at CSU, and then also with Robin Elmsley and her group down in Denver. So moved from studying T cells to looking at more non-specific immunotherapies, so really activating the innate immune system, so macrophages, monocytes, dendritic cells, and sort of developed a gene delivery technology for IV delivery, and then basically moved that up to Fort Collins when I was hired here at CSU, and continued to work on that, and then began to become more interested in the myeloid cell component of tumors, which by and large are mainly immune suppressive. So we've started to think about strategies to either get rid of those cells or to try and reprogram them so they weren't so immune suppressive. So a lot of the early work focused on monocytes, and that work continues to today, actually. So I think some of the most successful studies we've had have come recently with colleagues, Dan Regan here at CSU, Cheryl London at Tufts, using combinations of drugs to target these myeloid cells to either keep them from moving into tumors, or if they are there, to reprogram them so they're not as immune suppressive. So that brings us pretty much up to date to where we are now. And we're continuing to add new strategies to that basic platform of myeloid-targeted immunotherapy.
Yeah, it's all really interesting. It's always interesting to me, just the immune system and the different cells and how specific they are, but maybe not as specific as we think they are. So what's some of the more interesting research that you guys do there, or what have you found that's been pretty exciting advancements that you've seen over the years?
Probably just looking at new strategies to target these myeloid cells. You can do a lot of things in mouse models. Like, there's lots of reagents we can buy. But as soon as you start to move from a 25-gram mouse to a 25-kilogram dog, these costs just go through the roof. So a lot of the reagents we use in mice, we just can't use in dogs. So that really prompted us to start to look at practical alternatives to target these cells. And so we initiated a series of screening studies, either modeling in vitro or in silico, to find drugs that would target receptors on myeloid cells that could either block them from migrating or change their function. And I think the important thing we did was to restrict that search to only FDA-approved drugs and drugs that had been around for a while. So we knew a lot about their safety. They were affordable. We could script them. And so that was really where the screening started. And it's kind of where that whole myeloid-targeted immunotherapy program originated. So the first drug to come out of that screen was losartan, which is, as I'm sure most of the listeners know, is a drug for hypertension. Why would anybody think to use that to treat cancer? So that was why the screening was so important, because we could identify drugs that wouldn't have normally been thought of as having immune activity. And so we identified losartan, and actually pretty much all the drugs in that family of ARBs, angiotensin receptor blockers, have this property of they basically bind to the receptor that monocytes use to migrate and block its signaling. And once that happens, then they're not mobilized from the bone marrow. They don't move into the tumor. And as a consequence, within a few weeks, the tumor gets depleted of macrophages, which is really the cell that we've been most interested in. So the net result of that is you get spontaneous anti-tumor immunity, because the T cells that are in the tumor, they're sort of been paralyzed by the macrophages. Once the macrophages go away, those T cells start to work again. So losartan was really the first big breakthrough in terms of what we call a drug that can be repurposed. So taking a drug for a totally different indication, moving it into the cancer immunotherapy realm.
I love that, reusing old drugs, right? Because, well, I'm kind of thrifty to begin with, so I just like that idea. But it is great, especially for our dogs. And I think a lot of people don't realize the forethought you guys had, because the FDA approved, well, then we can use it off label. And like you said, we can actually script it out. We already know a lot about it. You know, a lot of these new drugs coming out, I can only imagine how expensive they would be to try to do any kind of research. So I think it's great. Yeah, when I've scripted out losartan for dogs and things, it is pretty inexpensive. You know, it's something most people can afford. So when you're doing that screening, I know you were explaining how the monocytes and the cells and things, how they affect the immune system and go through the body. But I still think that's pretty novel how you guys looked at different drugs and screening them to see how it would affect cancer. How did you guys come up with that? Or was there a foundation that you built upon?
Yeah, so it's a good question, Rachel. So I think the strategy was to target the immune cell, and then secondarily figure out which cancers it made sense to target. And so we had identified losartan as kind of our lead drug. And we also realized early on that it wasn't going to be effective as a drug by itself. So realistically, the idea that a single drug is going to do everything is probably not going to happen. So quickly looked around for a second drug we've combined. There was some data in mice that a drug called sunitinib had activity in targeting a different myeloid population, the so-called myeloid-derived suppressor cells, which are basically immature monocytes and neutrophils. And we have a very close homologue of sunitinib with tosiranib or palladia. We looked at combining the two drugs because they had different mechanisms of action, and turns out that the two together are really quite potent in the mouse models. And so we really designed our first dog studies around that combination of losartan and palladia. And we looked at osteosarcoma because we knew that the metastatic lesions were chock full of monocytes. So we knew that that was a tumor that if you got rid of the monocytes, you might actually exert some activity in controlling the tumor growth. The other point to make is that we learned some hard lessons. So we thought, great, here's losartan, as an internist, we know how to dose it, it's a mg per kg, no big deal. But when we did the studies in the first cohort of dogs, we really saw very little activity. We were looking at regression of lesions in dogs with metastatic osteo. So a pretty tough model to tackle. So we're pretty disappointed. We just really weren't really seeing much. And I remember a hallway conversation with Dr. Dan Regan, who was really instrumental in a lot of this work, where we just kind of wondered, should we abandon this program, or do we really believe in it? And should we really go back and do what, in retrospect, we should have done in the first place, which is to redo the PK and PD studies? A lot of the data was based in healthy dogs, but it was also based on a limited set of parameters, and they weren't really looking for the same endpoint we were. So a lower dose can control blood pressure, but to block monocytes and to engage this receptor, what we learned is you really need much higher doses. So we went back and did our homework, did a proper PK study, and what we learned was that you really need 10 times the dose that you'll see in plums, for example, to really see that activity. It's a really, really big dose. And I remember treating our first patient and just kind of hoping he didn't keel over from a hypotension. It was, really cute golden retriever, gave him this big dose. Everybody sat around watching him. He just sat and watched us back and nothing happened. And so what we learned was that really that dose in a dog that doesn't have pre-existing hypertension is just fine. We really have not seen any adverse events associated with hypotension. We do see occasionally inappetence, but it tends to be transient, but it's just a drug that's well tolerated at really high doses in dogs with cancer. And we've treated a variety of cancers now.
That's really interesting, just even the dose. And I found that too when I was first looking and reading through your paper, and I was like, okay, this is a lot higher, but they all seem to do fine. So, and that's been my experience, that the dogs I put it on have done really well. What other drugs have you guys looked into?
The original study, which is published now, was the combination of losartan and palladia. And, and we saw good activity in a tumor setting where it's really hard to see anything. As you know, these dogs with metastatic osteo just don't do very well. But we also realized there's a third myeloid population we hadn't targeted, which is the neutrophil. So neutrophils, when they're recruited to tumors, are also immune suppressive. So we had two drugs targeting monocytes and myeloid-derived suppressor cells. So then I'm working with Cheryl London, who had done a lot of work already with a drug called latorixin that blocks the chemokine receptor called CXCR1 and 2, which is what neutrophils need to migrate. We worked with Cheryl. We received funding from the NCI at this point, part of the Moonshot program. So in partnership with Cheryl, we added her third drug, latorixin, to the two-drug combination. We actually did a lot more screening than that. We had 6 individual small trials with other combinations. But the winning combination was the combination of losartan, palladia, and this drug latorixin. And that, when we put that combination together, we really saw good things happening. And we're preparing that manuscript now for submission. So we've done a pretty good sized study in dogs with metastatic disease, but then we also did an adjuvant trial in dogs that we felt like it was kind of a gutsy trial, but we treated dogs where they got no carbo, they got no adjuvant chemo. They only got adjuvant immunotherapy with this triple drug cocktail, and essentially saw equivalent outcomes to dogs that were treated with carbo. So almost identical median progression-free intervals and median overall survival times. So I think that for us, that was a win because it was a totally oral protocol, very fewer minimal side effects. Could be given essentially indefinitely, affordable. So we're really enthusiastic about that triple drug protocol. We're still waiting for that third drug to become available to the veterinary market. In the meantime, we are screening now for other repurposed drugs that we can use to target neutrophils, mainly because we really want to get the triple drug protocol out to the oncology community. Because one of our motivations all along has been to develop protocols that all of us can use, right? Where we're not relying on a drug company who may decide 6 months from now, hey, we're done. We don't need any more dog studies. So there goes your drug. So we really want to look at drugs that are widely available. So the fourth drug that we've looked at, and we're continuing to look a lot at, is propranolol as a beta blocker. So another totally repurposed drug. We're not treating bradycardia or arrhythmias, but it also has these really interesting immune properties, particularly on the myeloid-derived suppressor cells. So we've evaluated that combination, the propranolol losartan, in a brain tumor trial that was published last year in conjunction with a tumor vaccine that we're developing.
Interesting. And what do you think about propranolol? Because I've heard of it with hemangiosarcoma. I think it's, one of the other universities really looks at that. And it seems like the data has kind of gone back and forth over the years. Have you noticed it, like with what you're doing? I know you just said you looked at brain tumors, but I don't know if maybe even screening, if you've seen anything with hemangiosarcoma, or what tumors do you think, so far we talked about osteosarcoma and brain tumors. Any other tumors that could be helpful with these drugs?
I think potentially any tumor where there's a strong myeloid component to the tumor microenvironment. Hemangio is definitely one. That was the top tumor that we identified in a screen of immune infiltrates. It had the highest number of monocytes. Osteo was a close second, but hemangio is chock full of these monocytes that turn into macrophages. To be honest, we really haven't done much beyond just osteo and brain tumors at the moment. Hemangio would certainly be a candidate. As you know, studies in hemangio are tougher. Everything progresses so much more rapidly. It's more difficult to measure metastatic disease because oftentimes involves the liver as well. So we've just kind of steered clear of it. But I do think that combination could have activity, the losartan, and I would include palladia also. I know palladia alone doesn't have activity, and nor does it have activity against osteo, but you have to keep in mind we're using palladia in this setting as an immunotherapy, not as a cancer therapy per se. We're not interested in targeting the tumor cells. We're targeting the tumor microenvironment. So I could see an argument for a triple drug combo of losartan, palladia, and propranolol, for example. We have treated in a small pilot trial dogs with osteo with that combination, and seen a couple of responses. It's not enough numbers to make a strong statement, but I think there's a strong rationale for thinking that protocol could be effective. It's just figuring out what the outcomes are in hemangio, and powering the study appropriately are always challenging.
Well, and I like what you said about using palladia, is that we're not going after the tumor cells per se, but the immune system, changing the immune environment. So I think that really is a different train of thought than how I typically thought of treating those. So that makes a really good point. And you also mentioned with the brain tumor that you guys have a vaccine. Can you tell us more about that?
Yeah, so the published study, and actually Cheryl London and I just received funding from the Morris Animal Foundation to do a study in dogs with osteo with a similar vaccine, but it uses an adjuvant that came out of the early work my lab did with non-specific immunotherapy. So it's the liposomal adjuvant that when you add tumors, in this case, we were using vaccines made from tumor cell lines. So we're taking a lysate from those cells, mixing it with the adjuvant, and then that's given sub-Q at an interval of typically 2 weeks initially, and then spacing it out to monthly or every 3 months. But the advantage of using cell lines is we don't need a biopsy from the patient. We don't have to do anything with the tissues from that patient. We can make the vaccine and have it stored so it's available when the patient comes in. And we've sent the vaccine out to referring vets to administer. So that study, the brain tumor dogs, showed that the 2 oral drugs and then the vaccine could cause tumor regression in about a third of the treated animals and prolonged survival compared to historical controls. And I think the important thing about that study is the dogs didn't have any other treatment, no radiation therapy, no tumor debulking surgically. They only got the oral drugs and the vaccine. And that's essentially what we'll be doing in the osteo trial. So it'll be an adjuvant trial. They'll be getting the triple drug oral immuno plus a series of tumor vaccines. So I think you can kind of see the strategy here, which is to stack combinations where the mechanisms make sense, where they're either additive or synergistic, realizing that one or two drugs and targeting myeloid is probably not enough, but if we target the macrophages, the neutrophils, and then bringing something like a vaccine for the T cells, that combination should be more effective. So, it takes time. It's all an iterative process. And we're combining this myeloid-targeted cocktail now with CAR T cell therapy. So we have a funded trial now in dogs with osteo where they're getting the 2-drug cocktail of losartan and propranolol to augment the activity of chimeric antigen receptor T cells, which is our trial is underway now in dogs with metastatic osteo. So to our knowledge, it's the first trial in dogs that have ever gotten this CAR T cell. So we're very excited about that trial.
Yeah, it sounds like you have a lot of really interesting stuff all going. And, just thinking about these tumors, osteosarcoma and brain tumors, those are certainly ones in people that we do, sometimes some crossover research. Is that something that you've done as well?
Absolutely. Yeah, that's a really good point. The program from its very initiation was always intended to be translationally relevant. And our goal all along has been to move from mice to dogs and then quickly from dogs to either pediatric patients or adult patients. So we've actually had success in that model. So we have a pediatric osteo trial underway now at Children's in Denver. And it's basically exactly the protocol that the 2-drug cocktail was in the first osteo trials in dogs. So it's high-dose losartan in the kids with sunitinib, which is essentially palladia. And we're just now at the final cohort where we started to see activity in the dogs. So we're hoping to see activity in the children. That's probably our best example of quickly moving things forward. And again, the trial was easy to do in kids because those are all approved drugs. It didn't require much for the FDA to approve it. Obviously, the drugs are available. They knew how to dose them. So that's probably been our most successful example to date. But we are working with our colleagues at the medical school also for the CAR T cell work because they want to move these are all new CAR T cells. So they're not CAR T cells that have ever been in people. They've got some clever design features. So everybody's really waiting to see what the dogs do before pulling the trigger on a pediatric trial. So those are really closely tied together. So both pediatric osteo, pediatric rhabdomyosarcoma, and also pediatric glioma are all trials where we're looking for dogs for guidance. Yeah.
I think that's great because I don't think a lot of people understand how many drugs fail when they go from mice to people. I've heard in the oncology world, it's a huge fail rate. So I think it's really interesting personally how the dog could be a good in-between model, because he gets cancer naturally, they're larger size, the immune system. So, hopefully, and I know you guys aren't there yet, but as you see in these human trials, like maybe we'll see better responses than what you would at the mouse. What are your thoughts? Like I said, a lot of this is my opinion, except I've heard something like the fail rate for most oncology drugs is something like 86% or something crazy, something above 80%. But don't quote me because I can't remember the reference for that. But what are your thoughts on all of that, using the dog as that in-between model?
Yeah, you're exactly correct, Rachel. It is about a 90% fail rate. And there's a variety of reasons for that, but it does make oncology drug development really risky. It's probably the riskiest of all the drugs that are developed. So we believe that the dog then essentially serves to de-risk drug development. So either identify unexpected toxicities, and Cheryl's done a lot of good work in that regard, show combinations that make sense. Dave Vail and Rob Rabune and Davis have done some good work in radiation immunocombos. So looking for either failure or for evidence of efficacy to really kind of jumpstart and prompt the drug moving into patient population, adult or peds populations. But so I think the dog occupies a really unique niche in that regard as a realistic animal model to de-risk what is a really risky business in oncology drug development. And I think we're looking at it as a platform technology that can be applied to a lot of other drugs. So I can take losartan and losartan, mix it with a vaccine. I can give it with CAR T cells. We have a trial underway with Boss here at CSU with sinonasal cancer, giving it with radiation therapy, and seeing some really nice results in that trial on dogs that get the combination of RT to the nose with losartan and propranolol. So it's a versatile platform. And I think what we're doing now is just trying to understand what combinations make sense with that platform.
Yeah, and I liked too how, again, these are all drugs that we have. So we're getting so much information for the dog, helping with people. I like you guys are trying all these different combinations to see, what works the best and, what makes the most sense. I know you mentioned a couple of times combining propranolol and losartan. I personally haven't done that yet. Did you guys see much blood pressure changes with that? That's the only thing that makes me a little worried. But
yeah. No, I mean, not really. A couple of dogs, we did have to dose reduce the propranolol, mainly because of bradycardia. And we do ramp up the propranolol dose to, our targets is a mg per kg twice a day. We have to be a little careful with that combination. And I should make a note with the high dose losartan that we do exclude dogs that have renal disease or renal insufficiency. Or if we do include them, we're really careful because it can affect renal blood flow. And we're really careful giving NSAIDs concurrently with that combination, again, because of the concern about renal injury. So there are some caveats. It's not everybody can get it, but most dogs that don't have pre-existing renal disease generally tolerate either of those combinations pretty well.
Interesting. Yeah, no, I think it's great. And you said a lot of this has been published, and then otherwise you guys have ongoing trials. Are they all pretty much at CSU, or where can people find your research?
Most of them right now are at CSU, except for the new multi-center trial we'll be doing with Charlotte Tufts. And that triple drug combo was done with Charlotte Tufts also. The brain tumor trials will be here. The ongoing CAR T cell trials are here. But there is some, and Cheryl's running a triple drug immuno trial at Tufts with a different vaccine strategy. So there are other centers that are doing the trials. I know Davis is looking at adoptive immunotherapy with NK cells, with radiation. They've got what they call a super cytokine that really activates T cells and NK cells. So I think the field is really moving now to really embrace immunotherapy in canine and hopefully soon feline oncology. We are starting to look at squamous cell carcinoma in cats. Cats have sort of been ignored for too long, right? So we do need some options for them as well.
Well, that's perfect. You're looking at cats because yes, no one looks at poor cats. At least I feel like in oncology, they get left behind. So thank you, especially that tumor. That's a rough one. So if we can get any needle movement with that would be amazing. And you mentioned some really interesting clinical trials. What in general are you seeing, like maybe on the horizon, either with people or animals, that you think is really exciting emergent technology?
Well, I would say at the forefront right now is CAR T cells. Like everybody wants to know what the latest is on CAR T cells. And, if you have leukemia, they work great. Unfortunately, if you have solid cancers, not so great. So that's where the field is really focused right now on that technology. It's not going to be an off-the-shelf technology for dogs and cats, probably not in a near future for sure. I should point out Mickey Mason's doing some really nice work with an NK CAR T program at Penn. And hers might have the potential to be an off-the-shelf therapy, but the problem with CAR T cells is they're so expensive to manufacture that it really limits access. So I think, checkpoint molecules and inhibitors are great. They've been obviously around for about 20 years in humans. We have one on the market now. I think we're kind of all waiting to see what the data look like. But probably the newer, more exciting technologies are these so-called bispecific antibodies that would be delivered like a monoclonal antibody. So you can give them IV, sub-Q, but they serve to bring the T cell and the tumor cell together without having to grow the cells outside of the body. So the data from particularly people with multiple myeloma is just amazing. Patients that have been highly pretreated, failed multiple protocols, few doses of these bispecifics, and they've been in remission, 2 and 3 years. So I think that's probably going to be the biggest breakthrough that I can see being affordable and adaptable to veterinary oncology. It solves a lot of problems. It works with technology that we now have. It's just going to be a matter of picking the right targets and building the right antibodies. But that technology has gotten so much better in the last few years. And as you know, there are a number of products now coming on the market that are based on monoclonal antibody technology. So, Zoetis, Elanco, everybody's kind of getting into the game. So I think probably that's where the next breakthroughs will come from. And it'll be beyond checkpoint antibodies. I think we need to be looking beyond PD-1 and PD-L1 and CTLA-4 antibodies to these newer, more promising technologies.
Well, I like the biphasic. I never heard of those. So I'll definitely have to keep an eye out for that. And just a lot of these new products that you're talking about, it is really exciting. The monoclonal antibodies and just knowing that more of that technology is out that can also come down to veterinary medicine. So definitely excited, and we'll keep an eye out for all those other ones.
Yeah, they're coming. I think we get frustrated that it's not as fast as we'd like, but it's going to happen, and antibodies will become much more widely used in veterinary medicine, not just for oncology, but internal medicine, surgery. You name it, pick the right target. You can build an antibody.
Oh, that's really fascinating. So it'll be great to see where everything goes. And this has been an awesome talk. I love hearing about these different drugs and how we can use them. And I just really appreciate you being on our show. And before we wrap up, I always like to ask people who they think would be a good fit for this podcast.
Well, obviously the oncology community, but I think more broadly the general practitioner, because again, the drugs we've been talking about can be administered, with proper training. The repurposed propranolol and losartan's not a big deal. As you know, the toxicity comes with palladia and that combination. So knowing how to manage palladia is probably going to be the most important learning. The other drugs that we're looking at now are all out on the market. So we're just trying to figure out the next combination. But the combinations we're looking at are all things that the oncologist or the advanced GP can use. We've just got to figure out the dosing and the right drugs. But I think that's probably where the most immediate impact will come, is in some new classes of repurposed drugs that add to our armamentarium and add to the platform. But they'll all be oral, they'll all have low toxicity, they'll all be cheap, and hopefully they'll all be effective when you use the right combinations.
Those are certainly factors that everybody wants, especially in vet med. We like it to be less expensive, oral, know the dosing, well tolerated. So that definitely sounds like you know your audience, right? Like you know what vets and animals, what we like.
Trying to check those boxes.
Right. Well, this has just been fascinating. Thank you so much, Dr. Dow, for doing this. And for everyone listening, again, he's at Colorado State University and doing a lot of exciting research there. So again, thank you so much for being on our podcast today.
Okay. Thank you, Rachel. I enjoyed it. It was really nice.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Impromed.